Everyone, thanks again for joining us today for our pregnancy, parenting, and substance use focus on family health and well-being. My name is Fedora Preston Haynes. I'm a site manager with the National Council of Juvenile and Family Court Judges. And I'll pass it over to Rachel.
Hi, everyone. My name is Rachel Barnett. I am the Tribal Site Manager at NCJA FCJ. I'm so excited to present our fabulous presenter today, Dr. Kimá Joy Taylor, and I'll let her take it away.
Wonderful. Thank you so much for inviting me. I want to start with that. I'm really honored to have been invited. And I'm going to give you a little bit of my background, just to kind of level set, but I'll also talk a little bit about it during the conversation. This is a topic that's important to me, incredibly important to me. And I do hope that this will be a conversation. I'm not one of those people who says, I have all the knowledge. Every conversation, I learn something new. And so I hope it is a robust discussion. I am a pediatrician. I sit outside of Silver Spring, Maryland. You obviously can't see that, but I'm outside Silver Spring, Maryland, and worked in FQHC in Washington, D.C. for many years as a practicing pediatrician. I also, though, have kind of the 360 view perspective from other means. I worked in the Senate as a legislative assistant for Senator Sarbanes as a health, social policy, and women's policy legislative assistant. I also worked as a deputy commissioner, Baltimore City Health Department, at which many people know, whether they've watched The Wire or not. Baltimore City has a long history of substance use and trying to create holistic well-being responses to substance use. Also worked from there, left there, and quite honestly, it's because it was a huge job and I wanted to have kids and see a family. So left there and worked at a foundation. And then now I'm a consultant and do two parts of my consulting. One is really focused on research, and some of that research has been like, what are some of the hospital practices? Also, I will say I talk really fast. So if that happens, ping me. I try to remind myself, but feel free to ping me. So I'm reminding myself now. Some of that research was really focused on what our hospitals doing in terms of pregnant and parenting people use substances. Some of it is on workforce development within this space. So it's both qualitative and quantitative. And some of it's even broader. How do you think of creating programs that could midwifery or other programs that could serve holistically pregnant and parenting populations, whether they use substances or not? Other part of my work is really focused more on kind of implementing programs of this type. Like I do work in Baltimore. Um, as I said, I was deputy health commissioner, but a lot of the work, I don't know if you've heard of Be More for Healthy Babies, but it's this program to decrease infant and maternal mortality, and really do a lot to engage providers, train providers, educate providers, do other work on helping doulas, train doulas, and implement programs really to focus on family health and well-being. So that's the perspective I come with. I will say it's important to note that, like I said, I don't have all the answers. I know that this is a very nuanced space. I know that all of us, there's a lot going on from COVID on, and people are really exhausted. And so all of us really do want to see the best for the folks that we're serving, and what that looks like, and the circumstances are going to be different. And so it's important that we work together. So let's see if I can move the slides. I was like, I'll do my own slides, and now they won't move. So that's embarrassing. Um, I don't know why it won't forward. I will say that while I have a lot of expertise here, less expertise in technology. Let me see if I can move it from this. Seriously, let's see if this will work. Yes. Okay. So first, the disclaimer. The development of this presentation was supported by cooperative agreement. You can see it there. Points of view or opinions expressed in this presentation are mine and do not necessarily represent the official position or policies of OJJDP or the U.S. Department of Justice. So I like to start talks like this in terms of what is our goal. And when I think of the goal of myself as a pediatrician, someone who does healthcare policy, someone who's really working and serving families, it's really discuss how to provide effective access to and outcomes from effective health and social services for people who are pregnant and parenting and use drugs. Rooted in the idea that equitable rates of family preservation is a goal, not an accident. And I come to this topic, talking about this topic, with a realization, an honest realization that we're actually in the middle of a maternal child health crisis writ large, of which pregnant and pregnant people who use drugs are a subset. And so I say that to say, I'm going to say things that are like, we should have X. And often we don't have it. And I realize that. And it's aspirational. And so when I say every single pregnant person should have access to day one prenatal care, that may not be the reality where you are. But it's something about how do we get there? And it's a reality that's needed not just for pregnant and parenting people who use drugs, but for people writ large within the maternal child health system, because we do have a crisis overall. I will say some of the current barriers to pregnant and parenting folks who use drugs, as well as others, has been really a historical refusal to treat substance use overall, including in pregnant people, as a health concern. So we don't treat it as since it hasn't historically been treated as a health concern, it limits this access to effective therapies and supports because they haven't been developed. If they've been developed, they often haven't been developed at scale. And they haven't been, you'll hear this throughout. I'm also kind of a big person on whether they actually work, right? You can do stuff, but is it actually effective, and are holding people accountable for it being effective? And so our historical like refusal to really treat substance use as a health concern has been in a barrier. And I know people say, oh, well, we think it a public health concern, but I'm really going to break down what that means to make sure that we can move in that direction. Historical precedent of punishment being prioritized over health services have really made people fearful of engaging in prenatal care, which can and does lead to poor maternal and infant outcomes unrelated to drug use. And so this is where I alluded to that broader maternal child health problem. But if people don't come in for early prenatal care, it can lead to poor outcomes for both the mom and the infant. And in the instance of, like, say, hypertension, it can have devastating effects. But if people don't come in, you're not going to be able to assess that they have high blood pressure, and you're not going to do something about it. Society has focused so long on punishment that many folks are scared to come in. And so they don't come in for that hypertension, which is really often can cause more damage than the drug use. And if we can get folks in, we can work on all of it so that there can be better outcomes overall. This I alluded to, long history of poor maternal health outcomes. I should also say I have slides, but I often may go out of order. So long history of maternal health outcomes, poor maternal health outcomes across the population. And the health systems often prioritize physical health responses as opposed to behavioral health ones. And by behavioral health ones, of course, I mean substance use and mental health concerns, which are really important for holistic well-being. There's a lack of access to community-based, effective, non-punitive, evidence-informed, non-stigmatizing physical, mental health, substance use, and social services. This talk is going to be on substance use, but I promise you, as a physician who works in the physical health space and someone who refers into mental health space, there's a lot of stigmatization there, a lot of lack of access there. And so it's really important to holistically provide care for folks in all of these spaces that's non-punitive and non-stigmatizing. And this is a place where things really do have to grow. And it's something that I do a lot of training for physical health providers. Like, even if everyone's working with a patient and then you come in and are stigmatizing and mean, you've upset the entire cart that's going to affect their well-being. And then lastly, some current barriers are reporting laws that are intentionally punitive, often misinterpret federal law, or do not fit clinical realities. And by this, I mean, many laws are criminalizing, but often they're the laws that misinterpret what CAPTA is saying needs to happen, or say you have to achieve full abstinent recovery in 3 weeks, and that's just not the clinical reality around substance use. So I want to start the conversation around substance use as a chronic disease, because people say this, but when you look at policies, practices, programs, be they clinical, legal, public health, they don't reflect what this really means. They don't reflect the sentiment. And what that means is it translates into stigmatized, non-evidence informed care that people receive, and fear and punishment of seeking care. And that, as I said before, really affects folks' well-being, because so many of these things we can treat, the substance use, the high blood pressure, the gestational diabetes, but we have to make it so that people want to come in. And when I say we, I know I'm speaking to judges, so I mean we as in healthcare providers. And I often say that this is a space where judges, like all of the people in the legal system can help us push to make societies actually put those in place, because it will make not only the patient's lives better, but it also makes somewhat your lives better, because you'll receive for your clients. So let's talk about what I mean when I say substance use is a chronic disease. And some people say chronic relapsing brain disease. Sometimes I say chronic health concern, but this is something like blood pressure that is chronic. It can be treated and controlled, but like other chronic diseases, there's no quick cure. You may want it to be a quick cure as much as you want, but it's not quick. And it's not quick, particularly because we often don't have the evidence-informed services in place. So it makes it even less quick. But even when they're in place, it is a chronic disease. It's caused by behavioral, psychological, environmental, and biological factors. A lot of times people want to say, well, no one in my family could ever have a substance use disorder. Or no one I know. And one, that's not true. It happens throughout every community. But it's also not a switch that's flipped, right? It's caused by many different interactions, behavioral interactions, psychological interactions, environmental, biological, all mixed together. So you can't predict who is or who's not going to have a substance use disorder. It really does require engaging and talking to people. It truly changes the functioning of the brain and body. Once people have a substance use disorder, they're using to feel normal. And that is really important to know, because that means when they stop using, they feel truly abnormal. They're having true side effects that are painful. And so knowing that is going to be important when you have expectations of people and really then want to push them into evidence-informed care, because otherwise it's going to be really hard for them to succeed. Most people who use substances do not develop addiction. And this is really important and gets back to the second point I was discussing. People are like, well, you use the substance, and so by virtue, this is your fault. Many people use substances. And when I say substances, I'm using alcohol and other drugs. Lots of folks use them. They don't develop addiction because they don't have the behavioral, psychological, environmental, and biological factors that lead to addiction, right? So to say like it's your fault because you used it isn't really fair, since there's many people, like I always say for hypertension, you had that piece of cake. Not everyone who had that piece of cake is going to then develop hypertension. But those who have hypertension, who have those factors for hypertension, it may cause them to then develop hypertension that needs to be treated. The very definition of this disorder is continued use despite negative consequences. And so people are like, how can you keep using? That is actually the definition of this chronic concern. Continued use despite you continue using despite knowing these negative consequences, but you can't stop. It's a loss of control over use, choice and willpower are impaired. And that is what makes up this substance use disorder. And so a lot of our punitive responses to it actually go against what actually the disease is. I'm offering this. I am not going to read it, but DSM-5 is the textbook that we use to identify substance use disorders. And so understanding that, I'm just going to hit the high points. It's use despite harmful consequences. As I said, there's changes in the brains that make it really hard to resist those intense cravings, not the least of which that when you stop cold turkey can have really horrible side effects. The changes can persist, which is why it's called relapsing. People may return to substance use after they've had a long period of sobriety. Or so, for instance, for hypertension, you may get hypertension again, even though it was controlled for a period of time. So that means relapse is common, return to use is common, but it doesn't mean that the treatment failed. And that's important to know. So I'm going to get into more detail as I go along, but I do want to say, if you have clarifying questions, I told folks they could interrupt me and ask those questions. If they're broader questions, we'll hold those to the end. But if you're like, I don't really understand what you mean by that, definitely feel free to put it in the chat. So substance use disorders are chronic disease. We say this, but it doesn't follow. And so I want to compare hypertension and substance use disorder diagnosis and care. How and why do they diverge? And using that, and really I'm going to refer then throughout the talk back to that, how can we actually treat substance use disorders or chronic disease? Because that's going to affect then how we treat people, be it child welfare and these other spaces that we're also going to talk about. Comparison, diagnosis for chronic disease. So for substance use disorder, the way you diagnose is actually doing a verbal validated screen. There are screens out there, be they Cage and others, that you can utilize to see if someone has a substance use disorder. It is important to note that a drug urine test is not a diagnosis for substance use disorder. That is a point in time. That is like, so you really need to have this verbal screen to know what people are using, how they're using, to understand whether they have a substance use disorder. Um, Now, sometimes they can have what we call, like, you're using substances, but you don't have a substance use disorder. But you can still do a conversation. We call it brief intervention. You can still have these conversations around decreasing the possibility of further harm or possibility of moving into a substance use disorder. And I like to use alcohol for this one in the sense of someone may be using alcohol even though they don't have an alcohol use disorder. And you can be like, please don't drive, right? That is going to decrease the possibility of harm. And then have a further conversation about, well, why are you using? What are you using? What are some of the mitigating factors, except this brief intervention that will decrease harm, even though someone doesn't have an active substance use disorder. And that's important. That's something that often is not included in integrated practice, but it really is important because it gets to why not prevent some people from having harm and getting into that deeper pond. Then comes diagnosis. And treatment. And often for treatment, it is not the endpoint. It's in partnership with a primary health practitioner, the mental health practitioner, social services. And so it's not just going to addiction specialists or treatment center. It really is that holistic, integrated well-being and may not at times even require addiction specialist or treatment center. Like often the primary care provider can provide the buprenorphine or other services that people need. And so really has to be whole person care. So now I'm going to compare that to hypertension and be like, how do you know someone has hypertension? Well, you screen them. We had a verbal validated screen for substance use for hypertension. You can do a blood pressure cuff, which many of us have had, hopefully all of us, because we've been going holistically for care to our provider, but blood pressure cuff measurement. You can have the borderline. You may not be in what's fully known as hypertension range, but your blood pressure is a little high. You're a little stressed, it's a little high. So they talk to you about how to mitigate the harm. It's a conversation around, okay, maybe you need to exercise more, decrease the salt, think about what you're taking in. Because if you go into the hypertension pool, deeper in the pool, you can really have some negative outcomes. Diagnosis, you get to the diagnosis, and then you go into treatment. And sometimes, if it's really severe, you will go to the cardiologist for your high blood pressure treatment. But that again is not the endpoint. They work in partnership with a primary care provider, mental health provider, social service provider. And sometimes you don't have to go to the cardiologist, the primary care provider can take care of it. And this is really, really important because often we'll say, we'll differentiate. So if I send someone to a cardiologist as a pediatrician, I never say, well, go to the cardiologist. I hope that works out. But often in addiction treatment, you say, okay, I'm sending you to addiction treatments and I hope that works out. So, like if I send someone to the cardiologist has to get back to me. They have to write what they've done. When they've done it, I can follow up, I can reinforce, I can have the conversation around, well, the cardiologist said you shouldn't use salt, and you are like, how are you using salt? And not punishing them if they use salt, being like, okay, well, can I work with you on how we're going to think about decreasing that or decreasing adding it? Or I know a really great non-salt substitute, right? Whereas in treatment, often the system says, okay, go to the treatment specialist and hope that works out. And it doesn't afford the primary care physician to do that reinforcement, but it also doesn't allow for that other holistic well being of their blood pressure, of their diabetes, of their mental health concerns, and other pieces. And all of those often factor into the efficacy of your treatment. And so it's really important that or vice versa. Like, if people have an alcohol use disorder, are the medications that we're giving, is it interacting in a way that actually, like, so for insulin and diabetes, I want to know how much alcohol you're using because that'll affect your insulin and I need to adjust accordingly. And then we can have a conversation. So that's something that's not in place. But really, if we think substance use is a chronic disease, we should be treating it the same way. Similarly, when we talk about treatment for chronic disease, when you're in the treatment, you're going to have ups and downs. You may need to change treatment regimen at times. One size does not fit all, even for an individual person. For many, for substance use disorder, it's going to require counseling, may require medications, particularly in pregnancy. Those medications, their doses can change. You might need split dosing. And if someone returns to use, you shouldn't start all over again, which was notorious in substance use. Someone was in recovery, and then they used, and then we're like, you're out of recovery, you have to start from scratch. No, start with knowledge of current life experiences and realities. Be like, why did you start using again? Were there triggers that made it happen? Was your medication too low? Do we need to change it? Those sorts of conversations, which do happen in hypertension. No, I have hypertension. um Need to eat less and eat less salt, but you do have those chronic ups and downs, and sometimes when you're really stressed, I'm eating more Cheetos than I should, right? And my doc's like, okay, well, how can we help decrease the stress? May need to change your treatment regimen. Your medications may need to go up or down. You may need counseling if it's stress related, particularly. But if my pressure becomes high again, you don't start over. It's like, what triggered it this time, and how can we talk about with you and your life how we can help you moving forward? But like I said before, it's not substance use is not treated as chronic disease, and that has consequences. So there's a lack of access to evidence-informed substance use services, which lead to poor outcomes, including overdose and death. And this is inclusive of pregnant and parenting people. They cannot get access to evidence-informed substance use services, such as medications for opioid use disorder, such as counseling, such as, and the list goes on. And so that's going to, like, you wouldn't say, well, I'm stigmatizing hypertension, so I'm not going to get you access to the medications you need. Nope, but that happens in substance use disorder. There's a lack of evidence of access to evidence-informed physical and mental health services, which increase poor outcomes. And again, this is holistic care, so you need that access to the whole robust set of services. Um, because if the health system is stigmatizing and says we don't want people to come in who use substances, they could have poor outcomes for their hypertension, their gestational diabetes, and all of these. Like, it has to be treated as other chronic diseases. In here, as opposed to hypertension, admitting to chronic disease can lead to de facto punishment in criminal, legal, child welfare, education, employment, and other realms without access to services that can help avoid these encounters. And not saying that should lead to punishment anyways, but it always amazes me when people are like, well, we're going to punish people. We often early, I'm older, but early or here in my life, like early 2000s, there are all these studies around, is treatment better than incarceration? And it was always incarceration without anything. And you're like, of course. Right. And so often we're putting people in these spaces where they don't have access to really evidence informed care, and expecting different outcomes or positive outcomes. But also because of substance use, we've really embedded it into these other systems in punishing ways, like employment, education. It's hard to get a job um, if you have a record, and what does that mean and what types you can get. So it's de facto admitting to it has deep consequences. We don't even use evidence-informed ways to diagnose. We use drug tests, as I said, are a point in time. They are something that are often utilized in treatment to see how you're doing, but they're not a diagnosis. You really need to do that verbal validated screen to be able to diagnose someone, to really understand them. And ideally, with that screen, you're also doing some of the social screening, as well as some of the physical and mental health screening, like do you have depression, yada, yada. But we don't do that. And I think, even for this current um, opioid crisis, I always tell people, what if we had embraced substance use as a chronic disease long before? Do you know how many lives we could have saved? Because regardless of what the drug companies were doing, which were not good, regardless of what clinicians were doing, you would have been screening people and catching people early and having those conversations earlier, and we would have saved a lot of lives. But because our country refused to have a substance use system that really treated substance use as a chronic disease, we have really poor outcomes writ large, even outside of pregnant and parenting women. So it gets to, what should health and social service-based support look like for pregnant women who use substances? And this is particularly important for this audience because different folks will tell you different bills of goods of what it should look like, but you got to know what you should demand for the clients that come to you to try and seek that well-being and those outcomes and those positive, not just health outcomes, but family preservation and other outcomes. And I'll just say, like, when substance use changed from kind of a block grant response to more of a Medicaid response, there was this question like, what should it look like? And often the loudest talker would say what it should look like, as opposed to looking at the evidence. And that is really important because you're not going to have positive outcomes if you don't hold systems accountable, including my system, health system, for what they're supposed to provide and whether they're providing it effectively. And the goal really is to do this to increase wellness for parent-child dyad and to decrease harms from physical, mental, and substance use, health, and social concerns. I always say parent-child dyad because like it isn't one. As a mom, I'm like, we count too. We're people. We deserve services. As a child, they have to have services, but you're also a unit, right? And that unit functions together. So that moves from what should they look like? What should you guys be looking at when people say, well, she's getting care? What should you be demanding? And I'm going to look at it from a couple different windows. So, as I say, I always think about equitable access to and outcomes from, like not just focusing on whether someone goes in, but whether when they go in, whether it's actually effective and useful. And so, community based, non punitive, culturally linguistically effective patient centered services. And what that really means is any patient, you should listen to them. It's a lot of mumbo jumbo jargon, but it's like listen to the patient. You should be non judgmental, non punitive, and patient centered. What do they need? And in this instance, they really need holistic care, ideally before they're even pregnant, but for sure during and after pregnancy. You really want them to be able to have access to really comprehensive care and comprehensive prenatal care early. As I said, that is that fear factor, but in places that have built trust with their clients, they're able to get people in early because it does have profound effects on physical, mental, and substance use outcomes, and most profound effects even on those physical health outcomes. We need a full continuum of substance use services, including medication, which we'll talk about in the next slide, and non-judgmental services and easy access to services. And yes, again, I know as I say this, this does not exist in some communities, but there are movements to build it and have an understanding of what it looks like. And in many communities, there's access to Medicaid for these services, so we need to demand it for Medicaid. Need a full continuum of mental and physical health services. The number one cause of maternal poor health in most places, poor outcomes, excuse me, in most places are behavioral health reasons. So it's not just substance use, but also like depression, anxiety, and those pieces. So really need access before, during, and after to mental health, holistic mental and physical health services, and social services needed as needed, desired. And for some people, they don't need them because their family may serve as their social service provider. For others, they really need kind of maybe transportation, maybe case management. It is hard to navigate these systems. I said they had to go to mental, physical, substance use services. Those systems often don't have the patient centered in a way that you could have all your appointments in one place. So some people really need case management or other services that we're going to talk about post birth. So they should have access to and outcomes from those services. Compared with untreated opioid use disorder, pharmacotherapy is thought to have minimal long-term developmental impacts on children, but really massive positive effects on both parent and child. Providers should not perform medically supervised withdrawal unless the patient has requested. And so often, a pregnant person may go in to see a provider and they're like, all right, we're going to get you off the drug. Nope. Because that can actually sometimes cause um, either stillborns or miscarriages, but also it's really not in the best interest of the client. And it's because we talked about that relapse and other things. Like if someone goes back and then starts using again, particularly if it's IV drug use, like maybe they will then have HIV or syphilis, or like really being able to say, we're not going to do medically supervised withdrawal unless you ask. Because a lot of providers will be like, well, that's the right thing. They must be abstinent. During pregnancy, the right thing, the gold standard for opioid use disorder really is medications for opioid use disorder, like methadone and buprenorphine. And so if you see someone who, particularly against the patient's advice, we're like, yeah, we got them to withdraw, be careful. That's not the standard of care. It's also not a way to build trust with the patient, and often leads, because of the way the healthcare is interacted with them, decrease interaction with prenatal care and some of the other services that could have led to better outcomes. And so, we often blame the client, but we don't talk about how the systems actually led to that outcome. Routine urine drug testing without clinical indication is not recommended during the birthing hospitalization. And I've brought this up, I'll bring it up again later, but urine drug testing is not a test for substance use disorder. You really need to have that conversation with people. It's also not and it says without clinical indication, like sometimes very often it is used in treatment to see how someone is doing with their treatment. Is there still methadone in their care, etc.? But it really does require talking to the clients. And I will tell you, in the healthcare system, we often subvert that and do the clandestine routine urine drug test. You should have a conversation with the provider if that's what they're doing. Substance use services are about more than opioids, more than medications, and more than discrete treatment episodes. And though I just talked about the medications and the treatment episodes, and opioid use disorder, it's about more than that. People talk about solid polysubstance use now. That has been the history forever, right? People use more than just opioids, be it nicotine, which has negative effects on infants, more so than opioids and other drugs. People use alcohol. But so being able to offer a full range of services and asking, like what substance is the person using and do they have access to treatment? Many times you'll have often the way the policies are written, I will say it incentivizes this, but like someone has an opioid use disorder, so that's treated, and then they're kicked out because they were using meth. Well, you didn't ask about meth when they first came in, so they weren't being treated for meth. So how are you going to kick someone out, right? So really, it's more than opioids. Um, Nicotine, most common substance used in pregnancy. Quitting smoking benefits both infant and parent, and often there are services that can help people quit or at least decrease. Alcohol is a huge player as well. Stimulant use disorder, all of the drugs. And now, as many of you I'm sure know, that cannabis use is also now common. And often it's interesting and important that cannabis use often is not just because it's not because someone necessarily has a cannabis use disorder. It's because they're treating their nausea or something else. So it's really important that providers are having conversations about that because maybe they can offer something else. Um, and so I say this not to say that you all are to be healthcare providers. You are not trained as healthcare providers. You should not have that responsibility. But these trainings are also to say, like, what should you be looking for to know that this person was treated appropriately? It is not to give you another job. It is to say, like, and having someone on your staff or in your space in your court that really does have a deep understanding of what it is to say we should be demanding evidence informed care. Medications should be provided. Gold standard, again, brief intervention. Probably should have spelled that out, but that's what that BI is. And that's what I talked about before. Maybe someone's using and it could be harmful, but they don't have a use disorder yet. Like, are they having those conversations? Counseling, cognitive behavioral therapy. I'm going to give you guys these slides to take with you, and I will write out these acronyms. I apologize profusely. Cognitive behavioral therapy is a type of really effective counseling. Motivational interviewing might be contingency management. And then, as well as holistic prenatal care, physical, mental health, and social services. And as I've said over and over, because I'm a broken record, it can mitigate harm from other things. And now I just want to look at it from a slightly different window. Like, what is a continuum of substance use services in pregnancy? And for me, I think of this really robustly. And I will say, I don't just work in substance use services, I work in really holistic well being for adolescents and other spaces. And I think of everything really holistically. So, not all of this exists everywhere, but it's like, what if you had your, magic wand and what should exist? So, prevention. Many folks, we often talk about substance use in pregnancy, and um, I often talk about what comes before. There can be prevention, like, right, prevention of substance use, but also after a person has their first infant and goes to the next and maybe get before they get pregnant again. What does that prevention look like? It's not judgmental. It's not just say no, but it is a series of conversations, a series of services that exist that really provide that prevention aspect. Early intervention, that's when, someone has used perhaps and they haven't not harmful yet, but you want to intervene so it doesn't get there. Like brief intervention, what do those conversations look like? And they should be paid for. Secondary prevention, harm reduction. People often know of harm reduction as naloxone. Yes, wicked important. If someone's using naloxone, I mean, if someone's using opioids, whether they're illicit opioids or they were prescribed for pain, they should always have naloxone to prevent overdose. And those in their love circle, their orbit should have naloxone. But it's other things too, right? I think I will caveat also, I think of harm reduction very broadly. It is syringe exchange, what people often don't want to talk about. But that does decrease the rate of HIV, Hep C. But for me, it's also prenatal care, right? That is decreasing the harm. And so, what is that broad range of things that can reduce harm and lead to improved well being? It's substance use treatment. And I often say formal and informal. And I'll utilize that in a couple ways. I think of that in a couple ways. So, formal substance use treatment, where like a cardiologist, you are going to a substance use treatment center. Whereas in other instances, it's the primary care provider who can do it, right? Substance use treatment in terms of medication. If someone's utilizing opioids, nicotine, alcohol, there are medications for that. And in partnership with the provider, they should decide if they're on medications. For opioid use disorder, medications are the gold standard. For nicotine use disorder and alcohol use disorder, often that's decided in partnership with the client. And for a lot of these things, and frankly, that's for any medications, whether it's seizure medications or blood pressure medications or whatever it is, that needs to be discussed and what's going to move forward. Contingency management, often that is the most effective for methamphetamine use. Often it doesn't exist, but it is really a form of treatment that's been effective. Counseling, we talked about that. Recovery services. And this can mean different things to different people, much like prevention. So it is having a conversation. Sometimes it's housing. Sometimes it's, I want to go to, I am a pediatrician, so forgive me if I often revert back to adolescent things, but I want to go to a high school that where people, I want to go to a recovery high school where I'm not impacted and have to face the same people that I used with, right? It can mean different things to different folks, but there should be those recovery services, and often they're covered. But knowing to ask is important. Full continuum includes return to use. What happens with return to use? Is someone penalized and have to start over? And when that happened, it often meant you had to wait in the queue to start over. So you lost people. Or are they able, like with hypertension, to go back and be like, look, I returned again. Can I get an appointment within the next week to talk to you? It includes addressing the structural, political, legal drivers of health. As I said previously, substance use in this country had such a punitive bent that all of our systems included. And so addressing those, be it housing, be it your conversations with your probation person, be it the ability to get a job, all of those, your ability to vote, like addressing those drivers of health and well-being, and particularly mental well-being. Physical health services, mental health services, social services, addressing societal determinants, transportation. Can they get to you? Can they not get to you? And it really is also continued engagement no matter what. You used to be able to fire people from your practice because they use substances. You can't fire someone from your practice because they have brittle diabetes or because they have brittle hypertension. You have to continue engaging. Even if they keep eating the cake with diabetes, even if they keep using, you have to offer these other services. And if it gets to the point where you fire someone from your practice, and that's usually because they were physically abusive to your staff or others, knowing that you can send them to someone else. And all of these, this continuum is harder because of historical and current barriers, but we have to build the system and hold it accountable. And I think that's something in family court and juvenile court, like you can ask, do these services exist? You can be part of, like, you have great information on what people are telling you they want and need, and really help to build them in ways that people actually want to engage and use and are going to have the outcomes that that all of us, individuals, families, and society want to help see. We talked a lot about assessing for drug use. I do want to I said I was going to go back to urine testing, and here it is. Because I think often people use screening and testing synonymously, and they're not. They're interchangeably. A validated verbal screen is the gold standard to assess for substance use. Urine test is not. Um, and this is for many reasons, but like I said, urine test is a point in time. It is not a test for substance use disorder. It's not a test for parenting ability, and it's not a test for whether someone's going to abuse their child. And so it should be utilized sparingly. And a lot of people were like, well, we need to have it. And if we do it on anyone when there's no disparities, that's actually not true because There have been studies, and this could be a whole nother topic, but there have been studies, one to show the amount of false positives in drug testing, but also the way that clinicians don't always know how to interpret drug tests. And so even some of the metabolites are not what they think. But then also, everyone will tell you about the poppy seed, and all of those are true. So really that screening with validated instrument following patient consent. And if you are going to drug test, it's only for clinical indications and only with explicit written consent. And really looking at that because that affects what parents are going to say and what they're going to tell you. And it is not risk-free for parents to be honest in a screen, right? And so, being honest with them about that and being honest that, yes, if you tell us that you use a substance, you may be reported to child welfare. Um, you may have these other things. It's going to be really important, but it's also can be like, and now that you've disclosed, we are going to create a plan of safe care, and we're actually going to work with you to help you navigate this and try again to be as healthy as possible. So this topic is always nuanced, right? Because everything, it's like any other disease, you'd be like, of course you screen everyone for high blood pressure, but this has consequences, and so it's a slightly different dance with the patient. But all of it should be done with the idea that we actually want the best for you and your infant and your diet. Assessment needs to be person-centered, explain why you're doing all of it. And it does, like I said, allows the identification of people with untreated substance use disorder and should be the gateway to really quality care and high quality care. This is just to say that society or medical societies recommend universal screening. I have some honest concerns at times about that because, again, you can screen everyone universally. It doesn't mean what you do with them after is going to be fair, but it does really reinforce the idea that you need to screen as opposed to test. And many of the societies really do not recommend testing unless it's going to change what you do clinically. And that's true for any test, right? You wouldn't do a lumbar puncture unless you're sure that it's going to have clinical indications that are needed for improvement or not improvement of the patient. When people are like, well, we want to do it to make sure for the infant, there's actually a different assessment we do for the infant to see whether they're withdrawing. That's really important and necessary to do. But you also, again, you'll have the information to get people in care if you have a trusted relationship and do that valid screen. So, really assessing the relationship of the provider and their client, you can do it in these ways that are not as obvious, but it's wicked important. I've talked about this ad nauseum, so we're going to move on. So now I do want to talk about the infant. Again, I really want to stress mom-child diet. Often we focus so much attention on the pregnant parenting person, what's going to happen to the infant, which is a pediatrician. I think it's important to know what's happening for the infant, but we forget that the mother is a human. And so, as I'm about to launch into what's going on with the infant, that's why for the first part, I spent a lot of time on what mom deserves and that care that mom deserves, or whoever the parent may be. So, I do want to talk about neonatal abstinence. And many people call it neonatal abstinence syndrome. It's now more often called neonatal opioid withdrawal syndrome. That's because of the current opioid crisis. NAS often is broader than just opioids, but they get used interchangeably, so I have them here. But I do want to say it's expected and treatable outcome from following an in utero exposure to opioids. So when people are like, oh my gosh, this is going to happen, we know. Pediatricians know it's expected and it's treatable. And it's not going to happen for every infant, and it's difficult to predict which infant it's going to happen to. So back when I was younger, every child that was exposed to opioids or some other drugs was immediately sent to the NICU. That's not necessary. There are assessments that can be done to see who needs to go and who doesn't. But again, it's treatable. Non-pharmacological intervention should be initiated to help treat infants with neonatal abstinence syndrome and their parents. And I think of this as like mom is the best therapy, right? Treatment for most things. And so non-pharmacological intervention for folks who use drugs is really the same as many others. Breastfeeding, if parents would like to. If not, skin-to-skin contact while you're feeding the bottle. Room in after delivery. Pretty much those huge baby rooms are gone in most hospitals for all parents. Skin-to-skin contact, low stimulation environment. I said this already, not all infants require a NICU stay or medication for NAS. And it's been shown that a lot of this non-pharmacological interventions can actually decrease the need for medications. But should pharmacological intervention be necessary? Like, should the infant be having so many withdrawal symptoms that they need medications? It's based on an individual clinical symptoms and needs. It's not a one size fits all, and that should be done in close partnership with the provider and often with the pediatrician. And I say that differently because often in hospitals when an infant's born now, there's a hospitalist. It's not necessarily their pediatrician from outside, but the pediatrician from outside should know what's going on. Don't rely solely on parent or infant tox screens. Should be interviewed, should consent to that screen. And instant discharge planning should begin before birth. This is just a plug for pediatricians, but ideally, when you're looking at the chart, that parent or that mom family should have had a visit with the pediatrician before they even had the infant. And the reason I say that, and I say that for every child, it's because, but particularly in this, you want to make sure that pediatrician is going to feel comfortable with someone coming home from with with nows or with other issues, because that's also where providers get freaked and then stop doing what they need to do and may escalate the situation. So I like them to have a meeting beforehand. So they're like, they create a relationship with the provider, start having trust with the provider. That's where I talked about before. The hospitalist is now talking to the provider, and it's going to follow and be able to follow the plan of self-care, which safe care, which we'll talk about, so that they can have, again, best outcomes as possible. NAS is not an indication to immediately call child welfare police. And that's really important. Some people read CAPTA that it is, but it is not. And we'll talk a little bit about that. Discharge, much like other discharges, again, and discharge with other infants who may have chronic health concerns. Screen for the parent, for the mom, screen for symptoms of mental concerns before discharge from the hospital. Get them in a postpartum outpatient appointment. I'm not obese, so I can add to that. I actually think they need an appointment with their primary care, particularly if they've had like high blood pressure, substance use, other things. They need to re-engage with the person who's going to follow them after that pregnancy. And those folks need to be knowledgeable about NAS and accessible to the family immediately after discharge. And by that, I mean, like, if that mom comes home and the baby starts doing something, they need someone they can call immediately who's on call and can who help them. So you don't want to send them to a clinic that doesn't have after hours care or on call. Infants should get effective pediatric services, including their immunizations, their developmental screens, their clinic visits, in the same manner as other infants, focusing on the whole child and not just substance exposure. And I really hammer this not just substance exposure because I've seen so many times that folks are so focused on the infant and their exposure to substances that they ignore the fact that the infant's actually crumping because they have sepsis or because they have meconium aspiration. They go home, they're so focused when actually, and they do developmental screen. It turns out the child has autism, but they didn't give the early intervention services because they're so focused on the substance use. So really treat this child as a whole child, treat that mom as a whole mom, treat the diet as a loving pair that works in partnership if they're still together. And then health and social services providers develop and follow the safe care plan. And the plan should address, like I said, any maternal comorbid issues, recognize the physical changes after delivery. For those of us that are parents, we know it is exhausting having a newborn. You're tired, you're sleep deprived. If you had a C-section, you hurt. If you didn't have a C-section, you hurt. And so all of these may exacerbate the conditions or trigger a return to some form of substance use. And having being in partnership will, one, help identify the triggers, maybe, so you can stop it before it happens. It may mean you need a brief intervention. They used once. What does that brief intervention look like? Or return to more formal treatment. Like maybe they do have to go back to the treatment provider, but you're there and it can happen early. And so getting that immediate non-judgmental assistance if she needs it. So what could it look like if we prioritize positive outcomes? And that really is, like I said, my definition of harm reduction is so broad, but it really is early prenatal care. All the same prenatal care as everyone else. They should expect warm, non-judgmental, partnered care, and really focuses on all the screening and all the things. So then I talked about recovery, and I want to talk about it a little more because it is this process that individuals and their families kind of go through, right? And it's a process of change where they're improving their health and wellness, living a self-directed life, and striving to reach their full potential. And we often don't talk of recovery around pregnant and parenting people, but the interesting thing about pregnancy is that is like the number one time where people decrease their substance use on their own, right? It's not like um people often vilify pregnant people and are like, why aren't you? They're trying, right? It's a space. If you look at the studies, they are decreasing use on their own. And then when they get back, like, what do they need to have this self-directed life to improve their health and wellness and reach their full potential? So really having those recovery services, um, and knowing it's a normal part, relapse can happen. It doesn't mean treatment failed. Safety plans should identify and use approaches that anticipate the possibility of relapse. And so recovery is uneven often. How does your plan of safe care address and anticipate that? If you're connected, parents who are connected to appropriate supports and services can provide safe, supporting, and loving homes, even if they relapse. And this is really important to me. Again, we often vilify moms, but if you look at our history with alcohol in this country, often parents use alcohol. They do not have their children removed. They have the supports and services to continue to provide that safe home, be it having a babysitter if they're going out and drinking, be it having Uber bring them home, um, be it having a family support around, pumping your breast to get rid of the breast milk right after you used alcohol, and then proceeding along, right? So, what are those supports and services needed? We know we've done it before, actually. So, let's provide it holistically. And consider, when appropriate, not requiring a negative drug test prior to family time, as opposed to really having a conversation with the person. Um, so we are going to, we're going to get into child welfare, which I know was technically what this whole talk was supposed to be about, but I feel like that history was really important. And I promise there's going to be time for questions. So I am going to finish up in the next few minutes. Um, so what about child welfare? What if an infant has NAS? What if they have a positive drug test? What if I want the patient to get some supports and I don't know where to find them? Isn't the law to report everyone? No. And a lot of times, I will be honest with you, providers report because they don't know what else to do. It's not that they think it's the best thing, it's like, I don't know where the services exist. So some of the places that have really effective, like treatment court or spaces like get everyone together and be like, where are the services? And once you have the providers in the room, they're like, well, if I can actually send them to these services, treatment, and others ahead of time, I don't need to report because I have a relationship and I know what's going on. A lot of times providers report because they really think there's going to be this whole panoply of services on the back end. If it doesn't exist in community for advisors, for providers, it's not all of a sudden going to manifest for child welfare. So again, it's that building that what, but the law is not to report everyone. CAPTA has a long history. When it was first put in place, it actually did not require any referral for substance use at all. There have been several reauthorizations, and I'm just going to dive into some of the ones that have addressed it. So the 2016 CARA amended CAPTA and clarified it. So infants born with and identified as being affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or fetal alcohol syndrome. They removed the idea of illegal and they added this idea of affected. And that goes back to, remember when I told you that not every infant with an NAS, not every infant exposed to opioids has any manifestations of NAS. So that's important and gets to affected. But it's also important because people who do use methadone or buprenorphine may have NOWs or NAS. And so there's still some work being done in that space to be like, well, you are in long-term treatment and now I'm referring you. No, right? Like, what does that look like and what should that mean? It specified the data to be reported by the states, the maximum extent practicable. And for many states, for some of the data, people get notified, so they provide aggregate data. It's not individual data. It does, and this is the thing I keep mentioning, require a plan of safe care to address the health and substance use disorder treatment needs of the infant and affected family or caregiver. Require state monitoring of plans to make sure they're being implemented and utilized. And then there's a lot of variation at the state and local level about who's required to have one, who does it, right? Whether it's the provider or child welfare, and if they're different paths. And that's where I talk about notification versus reporting. Sometimes you have a path where you can notify CPS that there was an infant born opioid exposure versus actually doing an actual report. Um, and I'm going to send these, like I said, send you the slides to get so you can read those in full. But many of the models need to work to truly ensure they focus on parents who use substances and ensure they lead to positive outcomes, right? So you can do the plans. The plans have to work. They have to be effective. And they have to really take into account the parent. But with those caveats, they've been shown to promise and shown that people are thinking how to center the mom, the infant, the dyad, and family well-being and preservation. And so society is slowly moving towards a public health approach. I'm a pediatrician. I've seen many instances of child abuse that are heinous. So that is not saying that people who are actually at risk of or have sustained abuse should not have an alternative system. But in reality, substance use, as I just mentioned for the alcohol thing, is not that. Like alcohol substance use does not equal that you are going to abuse your child. And so many folks in society and many cities and states have moved towards a family preservation approach with supports and have been effective. But it really does require the development of those supports in the community that are non-punitive, relevant, and effective. It requires that funding and sustainable and reliable funding is available for them. And often that can be Medicaid can do part of those. I do a lot of work in Medicaid. I know it's being cut, but in the grand scheme of the cuts, pregnant people and infants are somewhat preserved. So how can you think about Medicaid as a utilization to continue such programming? And often they're short-term family-focused services that are really designed to assist families in crisis. They help with parenting and family functioning, which frankly, like every parent should have, but nonetheless. Um, and though they're often one not one size fits all, there's still some basic tenets in terms of the care that needs to be provided. Another funding source for this is Family First. And so if you're looking and being like, why don't these services exist? That's one place that you can start to look. And again, if people have questions afterwards, I can go more into that. And then I just wanted to mention a little bit about home visiting because people often say, well, just, once someone's born, put them in a home visiting. Yes, and it's kind of like the plan of safe care. It's more than just home visiting. It really needs to look at the whole system and whole people because even home visitors haven't often been trained and how to provide care to pregnant and parenting people who use drugs. And there's really institutionalized disparities in those systems, lack of information about evidence-informed services. Sometimes they'll say, well, you should, just cut off your medication for opioid use disorder. No. And so there is, home visitors have admitted they often feel ill-equipped to take care of patients, but it's also equipping them and having them be part of the conversation because home visiting can truly be wonderful and has been shown in some instances. And I'm also, when I leave, you're going to leave a couple of examples that's shown in some instances really to improve outcomes and not just outcomes like health, but like engagement with your child, returning to work, like all of these pieces with those supports if you have the training. And the other caveat, right, is when people don't have the training, and honestly, kind of everyone these days, a lot of burnout, high level burnout and turnover, which can affect the relationship with family. So having people really equipped to provide and wanting to provide the services is important. I'm going to lead these last two slides so we can talk, but these are just a couple of programs that have really home visiting programs that have really focused on pregnant folks who use drugs and parents who use drugs that have been shown to be effective. So that is it. I'm going to stop sharing. Oh, thank you. And it was a lot. And I talked fast and I am always available. You can always go back to NCJ, FCJ and ask for my information. I've met some amazing judges that I still am in contact with. So don't feel like this is one bite at the apple. But having said all that, questions, thoughts, examples of things that have really worked, maybe really not worked, anything. And anything I don't know, I'll get back to you. So if you don't ask a question, the horror is I will ask you guys a question. So, and feel free to put the answer in the chat. But what I'm just making sure the chat you haven't. What are some of the constraints when you're in this conversation? When you're, have someone come into your juvenile or family court judge? If you could say, courtroom, excuse me, if you could say, I just wish there were, and that would make this so much easier. Are there some things like what is the answer to that question? And centering like you, I know you guys want folks to succeed, right? So if there's one thing like, I just wish there were, and you can put it in the chat, but what are some of those things?
And please feel free to unmute yourself and speak.
Okay. Oh, even better.
Or put it in the chat like Dr. Taylor asked. Either way.
Okay, I've never been to an NCJ, FCJ conversation where people are silent. Looks just tired. All right, I'm gonna make it easier. Thumbs up or thumbs down. Do you like think just everything I said was nonsense? Or were there nuggets that were useful? If it was nonsense, down. If it was somewhat useful, thumbs up, and that's why you're so quiet. Phew. Okay. Um, I too like part of the reason I like to do these conversations is honestly, I do think judges have great power. People listen to them, and our services, and I say this as someone who provides services, they're not where they need to be. And it stymies, it then like carries on to what you all can do. And so if you all are advocates or at some of these tables really requiring us to do better, right? It's hard to say that because I'm talking about my colleagues. Um, for a couple reasons. One, we have to grow what's needed. And in rural areas, I would love if someone has the courage to speak up. Rural areas, it is so hard. People are not getting the quality of services they deserve, and it takes deep creativity to build them. But I do work with a lot of places, and sometimes having that legal voice there, judges being like, we would see less people if y'all could, is really important. So don't underestimate your power in the broader scheme, but particularly in rural places, like I think we need to be as creative as possible. Yep. Yes. Yes, Elizabeth. And it's not fair. I know someone like child welfare. I am a big fan of redoing child welfare completely. I'm not one of those, like I said, I know people get abused, so it's not I know child welfare needs to exist, but it needs to be redone. And part of it's like you have just workers, my God, with like 35 clients. Nothing, like you can't do your job. Um, so nothing good is happening from that. And so I would like the conversations that try to make things doable. I had a dear friend who said the only place you go that has to accept you is the emergency room and jail. And how is that what we want to have as our default, right? And so it really is creating those broad stream, upstream responses. And when I worked at the foundation, we did some work around diversion. And the most heartening conversation I had was where there was the prosecutor was harassing the social workers because they were like, y'all need to do your job. It was fascinating. They bought in completely to the diversion idea. They had done all the work to listen to constituents and what they needed and blah, blah. And they're like, wait, they're not getting it. And that voice of that prosecutor, because the prosecutor is also always the villain. But the prosecutor saying, what are you all doing? Like, why aren't you doing your job? And the folks were like, XYZ doesn't exist. And he's like, I will call the health commissioner. Like, it was just mind blowing their ability to move some of it because it just, yeah, it doesn't, it doesn't exist. People aren't trained well. And then, yeah, judges and child welfare bear a huge burden, but so do the families. It's like a no-win situation, right? Um, so I do. I do thank you for bringing that up. And yes, I will share the slides. I'm going to have to take a day or so because I have to get out all of those horrible abbreviations, which I apologize for. I really do try not to do that, but I will take them out. Lack of funding. Can I just I will say two things about lack of funding and to keep your eyes on. Child welfare is going through a lot of changes and on the national level, and I have deep fear that some of those changes will be lack of even more lack of funding. But on a positive side, there's kind of a rethinking what our expectations and outcomes should be, um, and redirecting our funding. So that's something to look out for and probably be part of those conversations. The other piece is Medicaid. I know we have absolutely seen all the cuts coming. That I stay up at night with the cuts coming. But as I said before, pregnant people and kids are somewhat protected. Pregnant people get an exemption from the work requirement. Kids absolutely do. And so thinking about that's why I was like, if you had a what if I could only like no lie, I was going to take that so I could use it for advocacy. But for you all to use it for advocacy as they're at those tables, like what would you like to see? Because that is one little place. Medicaid actually has much broader ability to respond to some of the needs of families than we often use. And so thinking about how you want to utilize it is where I spend like a sad amount of my life. Um, so yeah. If anyone, I will say this is pathetic, but Elizabeth, you say Medicaid is underexplored. Anyone ever wants to have a conversation around Medicaid, I have great slides and stuff on that as well. And frame from the point of like where are the opportunities. I fight to keep it as broad as possible, but we also need to look at the opportunities that exist as they do. Awesome. If this was supposed to be an hour, I was one who said I wanted to be an hour and a half in case there are questions. I stand humbled. So but if there's no more, we can definitely end it. But I do want to, before people go, I'm just going to put my email in the chat because do feel free to reach out. And especially after you get the slides, if something doesn't make sense or whatever. So I'll pass it back to you, Rachel.
Well, thank you so much for all the information. It was so great. I'm sure everyone feels the same, that we're walking away with all sorts of new knowledge and perspectives to put into action in our work. If anyone has any other questions, well, we did actually allot the time for 90 minutes. So I'm going to give everyone one more opportunity to ask anything. If not, then we can be done. And please take the evaluation that was put in the chat. Yeah. Thank you so much, Dr. Taylor. We super appreciate you.
Thank you. Yeah, and I'm so honored to be invited. I love NCJ, FCJ. So have a wonderful day.
Yeah. Okay.
Thank you so much for joining us today. And thank you so much again, Dr. Taylor. Have a great day.
Absolutely.